Pharmacists of Nigeria. So it's 9 o'clock, we're starting, but we'll just give 5 minutes grace for people to log on. And while we are waiting, please let's put in our names, PCN number, and our specialty group in the chat box to indicate our attendance at this meeting. Thank you. Most colleges. Distinguished colleagues, it's exactly 9:05. I believe we should start now because we have a lot. We don't want to take too much time. Others will join us as they come along. May I call on Professor Jordan, please, to give us the opening prayer. Professor Jordan, please, can you give us the opening prayer, ma'am?
Good evening, everybody. Let's pray. Our Father and our God, we thank you for a day like this. We thank you for the opportunity to Can somebody please mute from Gucci? Okay. Our Father and our God, we thank you. We commit this learning period into your hands. We thank you because you will grant us wisdom and the grace even to do all we can to assist those that need help in the area of TB. And you will equip us to be able to deal with TB indeed. In Jesus' mighty name we have prayed. Amen. Amen.
Amen. Thank you very much, ma'am, for the brief prayer. We appreciate you, ma'am. Once again, I'd like to welcome everyone to this special edition featuring the respiratory pharmacists of Nigeria and the infectious disease pharmacist of Nigeria. Tonight, I'll be moderating the event. I'm pharmacist Olani. I work at Lagos State University Teaching Hospital, LASUT. I'm an assistant director. So I'll be moderating tonight's event. On this call, I would like to appreciate the CPAN National Escort on call. I would like to appreciate Dr. Joseph Madu for his exemplary role and everything he has been doing to put the association together. I would like to appreciate Dr. Mutia Todulawal and all CPAN National Escort on this call. Thank you for all you do. I also like to appreciate respiratory pharmacists of Nigeria, the desk officers, the steering committee, as well as the infectious disease pharmacists of Nigeria for all their efforts to make this special edition a reality. So tonight, we'll be taking, today is 24th of March. We are celebrating World Tuberculosis Day, and we'll be talking everything tuberculosis tonight. So right now, without much ado, I would like to call on the desk officer for the respiratory pharmacist of Nigeria, Dr. Mrs. Oluwatoyin Ojo. So please give us a brief opening remarks as we go on. Dr. Oluwatoyin Ojo.
Thank you very much, Pharmacist Olani. Good evening to colleagues on the call tonight. It's a pleasure to have us on the call as we celebrate World Tuberculosis Day with a mind of ending TB, because that's the theme of this year's World TB. So by the grace of God, I'm the desk officer in the RPN, Respiratory. Nigeria, and I have it on the call tonight. I also have the attention to the RPN. Other members are probably going to join us. And they include Pharmacation Chairman, pharmacist as our project manager, and Dr. Hussein is our public relations officer. So the respiratory pharmacist of Nigeria is about everything that is respiratory. So we look into that to be able to add value to the life of our patients that come up with respiratory disease so that they can get better outcomes from their medication and devices where applicable. So we appreciate you for joining us tonight, and we look forward to you participating on all other activities that we put out there as respiratory pharmacists of Nigeria. So thank you very much. We appreciate other members of IDPAN that collaborated with us to be able to put this together. Please sit back as we enjoy what we have put up for tonight. Thank you so much. God bless.
Thank you very much, ma'am, for that brief opening remark. Right now, I'll call on Professor Georgia to give us opening remark from the Infectious Disease Pharmacists of Nigeria Specialty Group. Thank you, ma'am. Professor Georgia.
Okay, good evening again, everybody, and we're all welcome to this special CPAN evening that is being hosted by RPN and IDPAN. We are grateful to RPN for inviting us to come along with them on this journey to mark the World TB Day. And we believe that it will be a time for all of us to learn and also to begin to build our capacity with regards to managing TB and managing it effectively. I know that there are some of us on the call that are used as, well, I used to happen, I don't know if it still happens, community pharmacists used to be involved as DOTS managers to directly observe TB patients taking their medicines, and some of us, clients buy their drugs from us when they are not available in the hospital. You know, so we all need to increase our capacity and to be better equipped to even identify those that should be screened, those that should be tested, and those that should be directed to treatment. So we're all welcome. The Infectious Disease Pharmacists of Nigeria is one of the most vibrant specialty groups of CPAN, as we all know. We have weekly programs, including case presentations where members respond to the case of the week. We have a journal club. We have case studies, and then we have presentations where we invite notable speakers in the field of infectious disease to speak to us, to equip us, and to teach us. You know, so we are actively learning constantly, and we invite all of you to join us and join the Respiratory Pharmacists of Nigeria as we learn about TB today. You're all welcome. Thank you very much.
Thank you very much, ma'am, for that brief opening remark from the Infectious Disease Pharmacists Association of Nigeria. We appreciate you, ma'am. Thank you so much. Right now, I'll be calling on our presenter for tonight. He's a young pharmacist and is as well as a senior pharmacist. He works at Mainland Hospital, Yaba, in Lagos. Mainland Hospital is a place also known as Infectious Disease Hospital. It's a place where they treat a lot of TB cases. So it's very vast and renowned in that in the management of TB. We will be taking us on the topic management of TB tonight. He had his B.Pharm education from the University of Lagos, and he's been doing fine. So I'll call on pharmacist Ola Awe to please share his screen and come on for the next 30 to 40 minutes. Pharmacist Ola Awe, our presenter for tonight. Can you please share your screen?
Just to be sure that he's been made a co-host.
I don't think
okay, he is.
He has not been made it.
Good evening, everyone.
Good evening.
Just a minute. Just to be sure that you all can hear me, can someone just respond? Good evening, everyone.
We can hear you. Good evening, from Hawe. You're welcome.
Good.
Yes.
Good. Thank you very much, Ma. It's a privilege for me tonight to be the one presenting on tuberculosis on the World Tuberculosis Day. I'm excited and at the same time, I'm somehow frightened because I have my bosses on the platform tonight. Anyway, please, permit me to take a position on the current protocol. I don't want to pause tonight because the peculiarity with Friday's evening like this is for us to rest and ease off the stress of the week. So I'll just go straight into the presentation. The topic tonight is not new to every one of us. We all are professionals. So tonight I'll just be bringing back to our memory what we all have learned before, cases in which we have handled as regards tuberculosis. Management of tuberculosis. A brief introduction. Tuberculosis is a communicable disease caused by a type of bacterium known as Mycobacterium tuberculosis. It can affect the lungs. This is known as pulmonary TB, as well as other parts of the body, extrapulmonary TB. Organs affected can be the brain, the kidney, the spine. So let's just take a look at epidemiology. TB is curable, but still, it still kills about 4,000 people on a daily basis, and over 2 million annually. 80% of the world's TB burden occurs in just 22 countries, though I saw today in an article that is now 30 countries. And Nigeria is ranked 10th among the 22 high burden countries. But today also I also discovered that is now 6th. Nigeria is ranked 6th among the high burden countries of TB. And it is the third most burden country with HIV/AIDS. Our very own Lagos State carries 8.4% of Nigeria's TB burden. Let's look at some of the causes and pathophysiology. TB is an airborne disease. That is, it is transmitted through inhalation of air contaminated with the TB bacilli. When an individual with infectious tuberculosis coughs, sneezes, talks, and spits, they expel these TB bacilli into the air. And whenever they do this, especially when they sneeze, they release millions of these bacilli into the atmosphere. Talking, they release from 0 to 200 of this organism. But while they cough, they release 0 to 3,005 into the air. From the diagram we're seeing there on the slide, the individual to your left-hand side is the infected person, individual. He sneezes into the atmosphere and millions of these organisms are released. While the second person is the new infected patient, as he or she is inhaling the organism into the body. Exposure leads to infection. Infection could be latent or active disease. As you can see, the arrow beneath the latent phase, it can progress to active disease when the immune system is compromised. Let's look at some of the risk factors for tuberculosis. Like I said initially, I'm just trying to bring back to our memory what we all know. Risk factors include malnutrition or low body weight. Age also is a factor. Very advanced in age or very young. We all know that these two categories of people have their immune system low. Some drugs also, drugs used in the arthritis, Crohn's disease, and psoriasis. Also drugs used in preventing rejection into the body can also be a risk factor to TB. Ailments such as HIV, AIDS, diabetes, severe kidney disease, and cancer weaken the immune system, thereby making the body prone to TB. Other predisposing factors include overcrowding, alcohol, substance abuse.
Hello, Farm. We can't hear you again. Hello.
Hello, Mark. Can you hear me now?
Hello.
Hello. Can you hear me?
We can hear him.
I can hear you, but your voice is muted, kind of.
Oh, sorry. I guess it's my network. What about now?
It's better now.
It's better now. Thank you, Mark. So some ailments such as HIV.
Can anybody hear him?
Hello?
Yes, I can hear
can
him.
you hear us?
I can hear you. I can hear you.
We can hear him, so maybe network or something. I can hear him perfectly.
All right, can I continue?
Go ahead,
Hello?
go ahead, Farmer. Where is the moderator that cannot hear us?
Oh, all right. So can I go on?
Please go ahead. Go ahead.
All right, thank you, ma'am. Ailments such as HIV, AIDS, diabetes, severe kidney disease, and cancer weaken the immune system, thereby making the body prone to TB. Other predisposing factors include overcrowding, alcohol, substance abuse, indoor air pollution, and being exposed to TB patients or TB-infested areas. Signs and symptoms of tuberculosis. The most important symptoms of pulmonary TB is prolonged and persistent cough for 2 weeks or more. Other symptoms and signs are chest pains, difficulty in breathing, coughing out blood, fever, unexplainable weight loss, night sweats, and easy tiredness. Let's look at some of the complications of tuberculosis. Although this is not peculiar to pulmonary disease or pulmonary tuberculosis only, also extrapulmonary tuberculosis. Spinal pains, backache and stiffness, joint pain, arthritis also, meningitis, headache, and possible mental changes. Also, the liver or kidney problem also could arise from the complication of tuberculosis. Diagnosis. Sputum culture, chest X-ray, and mentors are the primary test that is being conducted to confirm if the patient is infected or not. Also, the molecular test called the gene expert LPA can also be done or as a confirmatory test. Principles of management, the direct observed therapy. This is very key. This is it's a method whereby a trained health worker or another trained person or designated person, also we can call them a treatment partners. They are the one that make sure they're watching the patient swallowing the drugs and they document it. And that is why it is called direct observe. There must be a treatment partner. And the treatment partner could be a member of the family, a member of the community, and the healthcare worker can be used. There are 2 phases of treatment. We have the initial phase, which lasts for 2 months, and continuation phase, which lasts for 4 months. Under pharmacotherapy, we'll see how this works. Drug-sensitive tuberculosis. TB regimen are described using a standard code where each anti-TB drug has an abbreviation. We can see the abbreviations in front of the names of the drug. So for rifampicin, it is denoted as R, isoniazid as letter H, parazinamide Z, while ethambutol is E. All these drugs are presented in a fixed dose combination, and we call them the CAT1 regimen. The regimen awaits days. This is very key. For the intensive phase, which lasts for 2 months, we can see on the slide, for a 70 kg patient, such patients will be on 5 tablets daily. And this is key because as a pharmacist, we must know this so that the patient will not be underdosed or overdosed. So for the continuation phase also, we can see the figures there. I just try to put in some drug resistance tuberculosis medications here. I'm not really diving into that, but I just put them here so that we could just refresh our memory. And for those that are not used to treating DRTB or NGRTB, can learn from this tonight. The drugs used in the treatment of DRTB includes bedaquiline, multifloxacin, clovasamine, protonamide, isoniazid, parazinamide, and ethambutol. This is the new WHO recommended regimen for DRTB and MDR-TB. Patient based on eligibility criteria. For MDR and DRTB, the total duration is between 9 to 12 months. As we have for the DSTB, DRTB also is treated in 2 phases. We have the intensive phase, which lasts for 4 to 6 months, with the use of bedaquiline, moxifloxacin, clovasamine, protonamide, parazinamide, ethambutol, and high-dose isoniazid. Pyridoxine is added just to mitigate the peripheral neuropathy effect of high-dose isoniazid. We also have the continuation phase, which lasts for 5 months. The drugs used include multifloxacin, clovasamine, ethambutol, and parazinamide. Also, vitamin B6 is added because ethambutol also could give a side effect similar to that of high-dose isoniazid, which is peripheral neuropathy. Let's look at non-pharmacological therapy. These just include the intervention of psychosocial factors. But these should not be focused only on the patient. The family too must be factored in, because if the family is one of the treatment partner and their psychology or social well-being is not stable, it could affect the patient directly or indirectly. And this could lead to multi-drug resistance or drug resistance TB. Prevention of tuberculosis. This has to be a collective effort. Reporting when TB is suspected is key. This could be in our vicinity at home, at our place of work, anywhere we notice. If you see anybody exhibiting any of the signs and symptoms, the suspect should be reported immediately. We can cancel such fellow or tell them, please go to so healthcare center, report yourself, lay a complaint. Isolation of infected cases. This is just to mitigate the spreading of the organism into the atmosphere. Prophylaxis for exposure in children by use of BCG vaccine. And for TB patients, maintenance of a well-balanced diet to keep the immune system strong is key. Among healthcare practitioners, the use of masks and respirator just to reduce the transmission among health workers is very key also. Patients with active TB should make sure that they are using protective masks and also cough into a tissue. And such tissue must be properly disposed after use. A case study. Chief complaint. The patient said, I have a prolonged cough and chest congestion for 2 weeks. The patient is a 40-year-old male with 40 kg weight who is admitted to the hospital presenting with a prolonged cough with mucopurulent spasm and chest congestion for 2 weeks. The patient reports a strong cough accompanied by hemoptysis. He also admits to having frequent fatigue, night sweats, weakness, and fever. No known drug allergy. Patient with medication history. He has been taking coamoxiclav 6 to 5 milligram tablets, syrup rosaline, tab vitamin C 1 gram, tab ibuprofen 400 milligram, TB metformin 500 milligram, and tab Dronine 5 milligram. The objective of the physician requested for chest radiography, tuberculosis.
Hello, pharmacist, well, like.
Seems like his network
Hello,
has
pharmacist, like he's not on the call again.
his network has logged him out. I'm sure he'll be trying to join. He's back in.
I'm not hearing you again.
He's
All
back
right.
in.
Okay, ma'am.
Hello, pharmacist, well.
He has not yet sorted out his volume. Okay, it's fine.
Okay, while he's trying to come in,
Pharmacist, can you? Okay, he's back in now. I think he should be able to speak. Hello, okay. He's sharing his screen. We'll be back in soon.
Hello,
Sorry
Mark,
for
can you
this.
see my screen now? I'm so sorry for that.
Yes, we can see. We can see you're sharing.
Okay, all right. The screen sharing is working.
Okay, you can continue now. We can see your screen.
All right, good. All right, let me retake the case study from the beginning. So sorry for that. All right, the patient's chief complaint was a prolonged cough and chest congestion for 2 weeks. And history, the patient is a 40-year-old male with 70 kilogram weight, who is admitted to the hospital presenting with a prolonged cough with mucopurulent sputum and chest congestion for 2 weeks. The patient reports a strong cough accompanied by hemoptysis. He also admits to having frequent fatigue, night sweats, weakness, and fever. No known drug allergy. Patient medication history. Coamoxiclav 6 to 5 milligram tablet, syrup rosaline, tab vitamin C 1 gram, tablet ibuprofen 400 milligram, tab metformin 500 milligram, and tab daolin 5 milligram. Objective: chest radiography, tuberculin skin test, sputum smell. All these were taken up for further investigation, and it was shown that the patient has pulmonary tuberculosis. Also done was the fasting blood sugar, which gives a value of 300 milligram per DL, and that is on the high side, and also HbA1c 8%, which is also on the high side. Now the patient was prescribed the 3 combined tablets of RZ daily, 1 capsule of tranexamic acid 500 milligram twice daily, tab metformin 500 milligram twice daily, and tab daolin 500 milligram once daily. Let's look at the assessment of the pharmacist. Drug therapy problem. Underdosing of anti-tuberculosis and anti-diabetic drugs. Non-inclusion of vitamin B6 supplements to counter peripheral neuropathy effect of isoniazid and ethambutol. Let's take a look at the plan. Therapeutic. Upward review of the tuberculosis drugs doses to fit the patient's weight. An upward review of anti-diabetic drugs doses. If we refer back to the table I showed, showing the drugs and the weight of the patient, we could see that what the physician prescribed, 3 combined tablets of CAT1, which is very, very low. The patient is a 40 kilogram patient, which means this is an underdosing for that patient. So one of the plan of the pharmacist is for the anti-tuberculosis drug to be reviewed. And also we can see that the patient's blood sugar wasn't controlled also. So the plan is also to review the anti-diabetic drugs and also include pyridoxine. Patient has to be educated also. Patient on rifampicin, their urine, saliva, sweat, tears, and faces also may turn red orange due to rifampicin. And this is to erase out any form of panic or unnecessary agitation from the patient whenever they notice this. Patients should also ensure to eat balanced diet, especially food rich in proteins. This will help to boost their immunity. What is the role?
Hello. From aware? Okay, at this point, I would like to, I will wait for him to come on again. I would like to recognize our senior colleague on this call, fellows of the Pharmacy Society of Nigeria, fellows of the West African Postgraduate College of Pharmacists on this call. Thank you for joining us this evening. I'd also like to recognize the Director of Pharmaceutical Services, Farm Homolambe. Thank you, my farm. Dego is the HOD of the Mainland Hospital Yaba. Thank you for being on this call, sir. In case you join us late or you are just joining, today is March 24th. We are celebrating the World Tuberculosis Day in commemoration of the discovery of the causative organism, Mycobacterium tuberculosis, that caused tuberculosis. So, okay, please, I'd like to know when Farm Aware comes in. So tonight he's been taking us through the management of tuberculosis. He's been taking us through the management of tuberculosis. He has talked about the risk factors. Who are those at risk? Who are those, what are the risk factors that can predispose people to having tuberculosis? So tonight is all about awareness, raising awareness about tuberculosis and how we as pharmacists can come in to manage tuberculosis better and also to prevent it. The theme for this year, World Tuberculosis Day, is end TB. Yes, we can end TB because why? It is curable and preventable, so we can end it. And how do we end it? By creating awareness, by letting people know that tuberculosis is contagious, it's communicable, and there are ways they can prevent themselves from contracting the disease. Like close contacts, monitoring, educating them, educating even people that are infected with TB on how they can better manage the disease without transmitting the infection to the population at large. It's a disease of public health concern and has to be well managed so as to contain it and to move towards the SDG goal, Sustainable Development Goal of ending TB by year 2030. So, Farm Aware, is he back? Not yet. Okay, so we'll wait for him.
He's not completely back. His video is in, but he has not inserted his volume remote, so he can't hear us and we can't hear him.
All right. Okay. I think he needs to remain the co-host again.
Yeah, he has logged off again. I think his internet is showing him today.
Okay.
That is out again.
Talk about the role of pharmacists. As pharmacists, what can we do? How can we come in as healthcare providers? How do we come in? How do we ensure that we manage our patients beyond supplying their drugs? We do a lot of supply, inventory management, and everything like that. But beyond that, we can do more as pharmacists. Yes, we can do more. We can interact with our patients. We can get to know their challenges to adherence. He told us it's weight-based, as tuberculosis can affect children, can affect the elderly, it can affect everyone. So there's a need to be involved to care for our patients. When we interact with our patients directly, we'll be able to pick There are drug therapy problems, especially those with comorbidities. Those are managing other diseases. Those that have immunocompromised condition like the HIV, people living with HIV/AIDS, people on chemotherapeutic agents, people who has had organ transplants, who are on immunosuppressants, people who are on corticosteroids. So many ways that we can come in as pharmacists to ensure that our patients, when they are taking their drugs, the drugs are optimized in them. They're not just taking the drugs, but they are getting the best from the drugs they are taking. Even storage, we can teach them on how to store their drugs so that the potency of these drugs should not get compromised before they use it. And at the end of the day, they might not get what they want from it. So as pharmacists, education is very important. We need to create awareness, we need to educate our patients, especially when we have people, you mentioned the signs and symptoms, when we have people that are coughing for more than 2 weeks, people that are losing weight, they can't explain how the weight loss is coming in, how they are, what could be the cause of the weight loss. They have nice sweats, they have fever, and they have used, people will have used different drugs, self-medication, even before coming to you. But when they eventually come to you, how do you advise them? How do you take them through so that they can be well managed? Most of these drugs are available free. They are very free. So as pharmacists, we can always encourage them to take their drugs. We can teach them on how to access their drugs. And most importantly, adherence to therapy. Can imagine most of us, when we have malaria, just 3 days to take anti-malaria, you find out that people find it difficult to adhere to therapy. Despite the fact that some of these anti-malarials, they are maybe once daily or twice daily dosing, you still find out that it's difficult to adhere. To talk of someone that has to take drug for months, very difficult. So we need to emphasize on adherence to therapy, and encourage people to take in their drugs. Then ADR monitoring is very key, and post-surveillance and marketing to ensure that possible ADR could be in so many ways. Could be as a result of a lot of things. Probably they are using it with some drugs. Probably they are on some other agents like maybe contraceptives, maybe herbal drugs, alcohol. So we need to take in all this to ensure that interaction with the drug is limited. You can see that he mentioned the constituents of the antitubercular drugs are the paracetamol, rifampicin, ethambutol, and isoniazid. Rifampicin is an enzyme inducer, so it will interact with a lot of drugs. So those that have comorbidities can have challenges on managing tuberculosis. We can come in there to encourage them on how to take their drugs, either to space it, to take one ahead of the other, so that the drugs do not interact. We can come in so many ways as pharmacists. And our role in the management of tuberculosis cannot be overemphasized. Pharmacists are where? Hello? At this point, can I call on Dr. Joseph Matthew, who's on this call, for a brief remark? The chairman, sir, Dr. Joseph Matthew. I don't think he's on this call. Hello, can you hear me?
Yes, we can hear you.
Okay. Okay. So far that he has gone because of our time, I'm sure you will meet us along the way. If you have any comments, you can take 1 or 2 comments before you comes in yourself by raising up your hand electronically, or you can send in a chat message. Comment, please. Dr. Foluke Ayeni, good evening, ma. It's one of the desk officers from the respiratory pharmacies of Nigeria. Please, can we have a brief comment from you, ma?
Good evening, everyone. I'm very happy.
Good evening, ma.
Good evening, ma.
I'm very happy to be part of this presentation, and particularly to have my knowledge of TB renewed this evening. Farmaware has spoken quite well. He has taken us through almost all we need to know about TB anyway. I just want to bring our attention to some of the risk factors that he has mentioned regarding TB. As pharmacists, we are looking out for the well-being of our patients, those that have the risk factors that we can refer to proper care. And I want to bring our attention just briefly to one of those risk factors, which is diabetes that he has mentioned. Studies have shown us that about half of those living with diabetes, about 50% of people living with diabetes are not even aware that they are diabetic. And that happens in Nigeria. And then diabetes as a disease is a known risk factor for the development of TB. It leads to the development of active TB and the reactivation of latent TB. So if a patient has latent TB that has not been treated, if peradventure that patient goes on to develop diabetes, then the latent TB becomes reactivated and goes into active TB, and things that contribute to more cases of TB. So I just want us in our various practices to also, in addition to looking out for the signs and symptoms of TB, to also try and look out for those that have diabetes, those that are currently managing it, and those that have it and don't know that they have it. We could test them to see, to check their level of the blood sugar level or the HbA1c to see if it's normal or not. And then those that are elevated, like the one he showed in the case studies, we can refer them for treatment so that the diabetes will be properly managed, and then they will not have any cause to develop TB. So it goes both ways, those that are developing TB fresh and those that are diabetic that could result to developing TB. Just for us to know as pharmacists that we should look out for this sort of patients. Thank you.
Thank you very much, ma. Dr. Felicia Williams. Kindly unmute and make your comments, ma. Dr. Felicia Williams.
Yes, good evening, all.
Good evening,
all. Yes, we appreciate the presenter despite the challenges with the network. Mine is a kind of comment. According to CDC, we have a 4-month TB treatment regimen that involves rifampicin and moxifloxacin. I don't know whether that regimen is being used currently in Nigeria. Hello?
Sorry, ma, can you take that again? Can you take the question again?
Okay. According to CDC,
Okay.
we have a treatment regimen for 4 months that involves rifampicin and mosifluoxacin. I don't know whether that treatment regimen is being used in Nigeria. Then according to the presenter, mosifluoxacin is used for multi-drug resistance or even drug resistance. But according to CDC, even mosifluoxacin can be combined with rifampicin for susceptible cases of TB.
Well, if I can make a comment to that, you know that the TB program, it's a government-funded program. And so probably what they are using in the program is, number one, what is being funded by their funders, or number two, what is the most cost effective for the money that they have. You know, so I'm not sure that we have pivoted to using Mrs. Awe, why are you sharing your screen?
No, it's not from Awe. It's from Olani, ma.
Oh, sorry, Mrs. Olani, moderator, why are you sharing your screen? You're sharing on his behalf.
Yes, I just want to wrap up with this.
Okay. You know, so I'm not sure that we have moved over to this new CDC requirements, but I guess if Farmawa is able to come back in, you'll be able to tell us exactly if that is one of the options that is now available in the government program, but I sincerely doubt it.
Thank you, ma.
Good evening, everyone.
At my hand.
Can I just make a comment on that?
Okay.
Hello?
Dr. Ojo, you want to say something, ma?
Yes, please. I just want to say that we have a pharmacist on the call from mainland hospital Yaba. Probably they could shed more light. Their colleagues and seniors of our presenters, they probably could shed more light. Mainland hospital is they call TB and other infections on a particular question regarding the regimen based on CDC recommendation. Pharmacist Sulaiman or other colleagues from mainland hospital, do you want to speak to the question?
Hello. Hello.
Okay,
yes,
sir,
we can hear
you. Please go ahead.
Yeah.
Thank you.
Good evening, everyone. As we well know, yes, we are resource limited in this part of the world. As of now, we treat TB at Mainland Hospital based on the categorization of whether it's sensitive or drug resistance, and those are the regimen, the drugs that we use, that we have access, because our drugs are founded by donors, mostly external donors, in fact, and we don't use mosifluoxacin for drug sensitive, TB. That's to be able to at least, aside of the guideline and the rest of it, we will categorically be able to know that, okay, is a first timer, the TB has is sensitive or not, and the rest of it. Yes, maybe moxacillin will actually give a fast remission when combined with rifampicin and the rest of it, but that's not in the guideline of treatment currently.
Thank you very much, sir. for your contribution.
You're welcome.
At my end too, that's at last week. We see a lot of TB patients, and they have not migrated to the use of that rifampicin or moxazicillin. We are still on the four drugs that we've been using. That's paracetamol, RAZD, rifampicin, isoniazid, and ethambutol. So on this note, I'm not sure Farmer will be able to come in. I just want to summarize what is before we take in more comments and we'll wrap up for the night. So Farmer has been able to tell us what tuberculosis is. He reminded us, about what tuberculosis is. TB epidemiology, the mode of transmission, stages of TB infection, that's the exposure, the latent, and the active phase. And the different types of TB. Drug-sensitive TB, drug-resistant, multi-drug-resistant, and extensively drug-resistant TB. So early discovery will lead to early recovery. We should be able to identify through the signs and symptoms. He has also made us, he has also talked about the management of TB, being weight-based, and emphasized that adherence to therapy is very key. Then he talked about management of drug interaction based on the case study he presented. He talked about the preventive strategies and how we can control transmission of TB. So TB everywhere, TB anywhere is TB everywhere, because anybody that has TB in any population poses a risk of transferring the infection to the population. So it's time to step up and search for the missing TB cases in Nigeria. It's time to look for the index cases and treat, as well as the contacts. Yes, we can end TB as we celebrate today, the World Tuberculosis Day, March 24th. Thank you. We'll take in a few more comments now before we wrap up for the evening. Few more comments, please. If you want to make one or two brief sentences, can you please indicate?
Good evening, everyone. Hello, good evening, everyone.
Good evening.
I don't know, I thought I had
Good evening, ma'am.
Good evening, how are you? My name is Mrs. Lawal. I thought
Okay,
I had my address, but I don't think it's up. So
okay,
it's been
you can go ahead.
evening, and I always like to come in from the angle of community pharmacy practice, especially based on experiences. A lot of work rests on us in this management of TB, particularly looking out for drug therapy problems, and there are many of them. More because these patients access care primarily somewhere else because it's government sponsored program. So most of the time they don't come to us for the treatment, and we may not know that they're on these medications. They're presenting with prescriptions of drugs that could interact with their TB drugs. So it's important that we clerk our patients properly and get information. Some years ago, I had this patient that wanted TB drugs called, and well, because we hardly have patients on them, since government gives it free, we hardly stock them, we get per patient. But when I interacted with him, I found out that he was diagnosed to have TB 5 years earlier, and he had been treated. He now said anytime he had a cough, he would go and start the medication, take 2 or 3 weeks and stop. And he had done that for 5 weeks. And he was buying these drugs to pharmacies, according to him. He said they assumed that he must be on the medication. So nobody was asking him if he had a prescription or anything. And he was oblivious of what he was doing to himself. So we had to refer him to the center. And naturally, we were worried about his organs, his liver enzymes were raised and all that. And he was TB free. He didn't even have TB anymore. So there are so many cases out there, and we have a lot of work on us to come out there and solve many of these challenging problems. It's quite challenging because of the environment we are in, because the patients can see 10 different doctors in Nigeria and bring all different types of prescriptions. You can go from one pharmacy to another to get drugs. So it's usually quite overwhelming, but we still have to do the bits or the much that we can to help them, especially focusing on medication therapy problems. And like you rightly said, diabetes patients are at risk. I lost a patient of diabetes some years ago to TB. It wasn't the diabetes that killed him at the end of the day. It was the TB. And because people have a lot of myths around this condition, they don't want to be stigmatized and all that. Sometimes it's very difficult to know. I had just many experiences, and I just think that we need to come out more about it, talk publicly about it, and then look out patients that need our help so that we can go the extra mile to help them. Thank you.
Thank you very much, Ma. Pharmacist Oluwajeda Folashade Kotun.
Yes,
Please.
good evening, everybody.
Good evening,
I appreciate the presenter, and I want to just ask this question because we had a patient in my facility. After concluding the 4 months phase, the first 2 months and the remaining 4 months, the sputum test was repeated. It was negative, but there were still signs. The patient was still coughing. And even before the commencement of the therapy in the first place, the patient had sputum test negative. It was because of the X-ray that was done. That was why they decided to start the patient off on the DOTS regimen for TB. So I want to ask, in cases like that, is that is the patient going to repeat the regimen all over again? Because even at the last test for the sputum, it was still negative. She was asked to go and do a chest X-ray, but we've not seen the client come back after that. Then, apart from that, concerning the multi-drug resistant tuberculosis, currently now, and I want to direct this to our colleagues at the Milan Hospital. When do they start the regimen for that? Thank you very much.
Thank you very much, Ma, for your comments and questions. We'll take the last comment from Pharmacist Omolola Okuma. Then Pharmacist Isa, sir, you would answer the question for us. Pharmacist Lola Okuma.
Yeah. Good evening, everybody.
Good evening.
Well done. Kudos to the good work. This particular topic is an important one, especially for community pharmacists, because that is where we call the first port of treatment. Many years ago, when I had my community pharmacy, they had this client who schools in South Africa. So she was on Nigeria for vacation, and she was having this cough. As usual, I start with an expectorant, gave to her. It wasn't working. We moved to suppressants, gave to her. It wasn't working. Next thing I told her, come into my car. Let's go somewhere. I took her to infectious disease hospital, and it was detected that she had TB. So this is a topic that, in fact, all community pharmacists should be here to help us catch them on time. And she was so grateful to me because she said, when she's going to South Africa, she's going to change her hostel. Probably she caught it from her roommates in the hostel she was staying while she was in South Africa. So thank you for bringing up this important topic. Thank you very much, and God bless.
Mrs. Morokoma. Mrs. Elias Eze, please type in your question while we wait on Dr. Isa Abdulmumin to answer the first two questions. Pharmacist Eze Elias, please type in your question. We've taken our last comment. Please type in so that I can read it out when Dr. Isa gets through with this. Thank you.
Okay, good evening,
so the
everyone.
first question was, okay, you got it.
Okay, what is the first question, please?
The pharmacist Fortune said Fortune negative, but the person was still coughing. That what could be responsible?
Yeah, sputum negative result doesn't necessarily mean a complete cure of the infection in the person. And so it doesn't mean that the person has been cured and doesn't need treatment again. What we know in literature is that people that are sputum smell negative are less infectious than those that are sputum smell positive. So it's not a proof that the person has been treated or cured completely of the infection.
Thank you, sir. So I have this question from pharmacist Yang. She said, how much local remedies can we put in to mitigate the spread, saying that we are in a resource-limited setting? Are there local remedies to put in to mitigate the spread?
I don't know what the questioner meant by local remedies that will prevent infection. But if it's talk about taking care of measures, that is personal protective measures, not advising the people on how to cough and covering themselves, and whenever they have any little symptom, they should go to a healthcare professional, not to keep themselves at home treating cough with different types of cough syrup for over 2 months. Usually, if they start seeing things like blood in the sputum, I think that is what I understand. What I know by local remedy, but if she means or if he means alternative medicines, I don't have knowledge of that.
Thank you, sir. In addition to water ways, non-pharmacotherapeutic way, will be good nutrition. Once the immune system is fine, we should be able to restrict the infection. Even if someone gets exposed, it might be at most maybe latent TB, which is not infectious. Pharmacist Eze Elias. Sorry. Okay,
Hello?
Dr. Jordan said, in addition, since the patient was diagnosed based on chest X-ray, then the progress of therapy should also be based on that. If the person's chest X-ray comes back and is still indicative, then they may need to assess him for DRTB. That's for sputum negative but still coughing. Someone that is sputum negative but still coughing. Eze Elias talked about how relevant is Mantoux test in TB diagnosis again. How safe is BCG, a live vaccine, in HIV-exposed babies? How relevant is Mantoux test in TB diagnosis? Well, for me, if I would say it, Mantoux test is one of the diagnostic tests, and is also used as a screening test because GeneXpert is like a confirmatory test used in the management or in diagnosis of TB. It's quite expensive, so not everybody can go on GeneXpert test. But for Mantoux, it's usually used in population for screening and then to identify those that you might want to go further to investigate. It says, how safe is BCG, a live vaccine, in HIV-exposed babies? Live vaccines are not really encouraged in immunocompromised patients. They are not encouraged.
That it should not even be used. It does
Yes,
not
sir, you're saying
at all.
Dr. Isa?
Yes, I said that the WHO even says that
Yes.
BCG does not provide any protection in tuberculosis for HIV-infected infants, and so there's no need to use it at all, apart from the issue of its safety. There's been a live vaccine for someone that is immunocompromised because HIV exposed. The person should not be given a BCG vaccine.
Thank you very much, sir. On this note, I think we can wrap up for the night. Thank you. It's been an amazing time. Thank you for staying till the end of this meeting. I appreciate everyone on behalf of the Respiratory Pharmacists of Nigeria and Infectious Disease Pharmacists of Nigeria. We appreciate your presence tonight.
Before we close out, I
Okay,
just wanted
ma.
to draw attention to the flyer that was created for this event. I actually sent a message that we should actually show that flyer, and we know that the flyer was created so that we could use it as pharmacists, number one, to remind ourselves of what we know about TB. And on the back of the flyer, there is a form that you can fill for patients that you suspect or you want to screen for TB. There's a portion at the back of that flyer that you can use to actually screen patients or clients that come to your pharmacy, and you can then profile them for further treatment, for confirmation, and for expert care. So I just felt we should mention it since the flyer was created for this event.
Thank you. Thank you very much, ma. The flyer is on the platform, so we can access it on the platform to use to create awareness and also to screen our patients. Thank you so much, ma. On this note, can we take the closing prayer? Pharmacist Olayinka Rukayat. Pharmacist Olayinka Rukayat, can you unmute and give us the closing prayer?
All right. Good evening, everyone.
Good evening.
It's been a wonderful session, and thank you to the presenter, the moderator, and every other person that has contributed in one way or the other. In the name of Allah, the most gracious, most merciful, praise be to Allah, the Lord of the world, the beneficent, the merciful, Master of the day of judgment. You alone we worship, and you alone we ask for help. Guide us onto the right path, the path of those with whom you are pleased, not of those who incur your wrath or your anger, nor those who go astray. I pray that God will be with us as we go to sleep this evening, and hoping that the knowledge we have gained would impact the life of our patients and the population in general. Amen.
Amen. Thank you very much. Thank you, everyone. So the flyer is being displayed again on the screen. We can access it on our various platforms, on various pharmacy platforms. Thank you for coming in tonight. We appreciate your presence.
Thank you very much.
Until the next time we meet again. Bye.
Good night. Yeah.
Bye. Bye.